Good afternoon to everyone. You may recall a childhood story about a princess who was made to sleep on top of 20 mattresses with a tiny pea at the very bottom of the pile. It was done in order for the queen to make sure she really was a princess, because she would be sensitive enough to feel the pea under all those mattresses. True enough, when she was asked how she slept, she answered, "Oh, very badly. Heaven knows what was in that bed, but I was lying on something hard, so that I am black and blue all over my body." Imagine that, a fairy tale about a girl with easy bruising. Is it because she was a real princess? They say only a princess could be as sensitive as that. Or is it possible that she has an underlying bleeding disorder? And this is what I am tasked to talk about today: the diagnostic approach to easy bruising. It is our aim that at the end of this short lecture, we should be able to apply the general approach to a patient presenting with easy bruising and/or bleeding, identify the common differential diagnosis of patients with easy bruising, and recognize and diagnose cases of easy bruising. Let us first have a brief review of hemostasis. Normal hemostasis is a highly complex process to maintain the integrity of our vascular system. When platelets and clotting factors circulate in an inactive form, blood flows freely through the vascular system. However, vascular injury and the resulting disruption of the endothelium trigger the complex hemostatic response, broadly classified into primary and secondary hemostasis. Primary hemostasis will involve mainly the platelets in three stages: adhesion, activation, and aggregation to form the platelet plug. And then, it is on the surface of these aggregated platelets that secondary hemostasis will then take place. In this next phase, the coagulation or clotting factors are activated, proceed to go through the coagulation cascade, with the end result being the generation of thrombin and achievement of final hemostasis. But what is a bruise? Bruises or ecchymosis are skin lesions caused by capillary bleeding. They are large lesions that are flat and usually not palpable, unlike true hematomas that are accumulations of blood in the skin or deeper tissues. Ecchymosis and hematomas, sometimes also referred to as purpura, are generally larger than 3 millimeters in diameter, compared to another sign of bleeding called petechiae. These measure less than 3 millimeters in diameter. All these cutaneous lesions are signs of bleeding that may or may not translate to a serious hematologic disorder, and we will discuss them later on. As with any other illness, it is essential to obtain a very good history, thorough physical examination, and laboratory evaluation in any patient with bleeding or easy bruising. The information gathered from the history and physical examination will ultimately dictate the extent and duration and direction of the laboratory tests you will request for. Generally, a good history for bleeding and bruising can be obtained within minutes by asking a few specific questions. Is the bleeding real? Is it a platelet-type bleeding, meaning a problem with primary hemostasis, or a coagulation defect bleeding, or a problem with secondary hemostasis? Is it acquired or congenital? And what tests do I perform and how to interpret them? Defining easy bruising is actually very subjective, and eliciting the seriousness of bruising or bleeding symptoms even more so. Patients can either underestimate or overestimate the severity of their symptoms. This is why patient perception of bleeding may not always be useful in diagnosing a bleeding disorder. A patient's perception of their own bleeding tendency is often understated or exaggerated. If a patient complains of easy bruising, determine the location and site of bruising or bleeding. Bruises in an unusual location or patterns may suggest trauma or physical abuse. If easy bruising is associated with other bleeding episodes, we may be dealing with a systemic disorder. So if there are other bleeding episodes, the duration and severity of the bleeding should be elicited. For female patients, always remember to take a detailed menstrual and obstetric history. Menstrual histories often provide clues for an underlying hemostatic defect, especially for those with persistent menorrhagia or a microcytic anemia despite adequate iron supplementation. If a patient has frequent epistaxis or a recurrent epistaxis, the possibility of a von Willebrand disease may be considered. Hemarthrosis, retroperitoneal hematoma, or soft tissue hematoma formation not associated with any trauma, if present in a patient, are typical manifestations of coagulation defects or problems in secondary hemostasis. Next, we should ask about hemostatic challenges the patient has experienced and what the response to that hemostatic challenge was. A useful question is, have you ever experienced a serious bleeding complication during or after a surgical procedure? For women, did they have excessive bleeding after childbirth? For males, you could ask them about any bleeding complications after circumcision. If there are no prior surgeries, you could ask about even minor events like excessive bleeding after a simple tooth extraction or after minor trauma. Examples are razor nicks or small cuts on the skin. When they brush their teeth, do they bleed excessively? But also remember, if there has been no prior hemostatic challenge experienced, a silent bleeding history does not rule out a mild bleeding disorder. Second question, is it a problem of primary or secondary hemostasis? Remember that primary hemostasis involves mainly the platelets and secondary hemostasis involves the coagulation factors. Patients with bleeding due to platelet defects will typically manifest with mucocutaneous bleeding. They will have excessive bruising, gingival bleeding, frequent nosebleeds, or excessive menstrual bleeding. Whereas patients with coagulation factor deficiencies will tend to have bleeding into muscle and joints or hemarthrosis. In any hemostatic challenge, like surgery or trauma, however, both groups of patients may bleed excessively in the same manner. If the patient presents only with easy bruising or hematoma formation, it is likely that the problem lies in primary hemostasis or the integrity of the blood vessels. The third key question is it an acquired or inherited bleeding disorder? In all cases of possible bleeding disorders, family history should be obtained. If there is a family history of bleeding, think congenital or hereditary bleeding disorder, but the lack of family history does not entirely rule out a hereditary bleeding disorder. Because patients may not be aware of their family members' medical histories. The genetic defect may have variable penetrance. The coagulation disorder may lead only to a mild bleeding diathesis, not always manifested clinically, or the mutation may have occurred spontaneously. And when eliciting the family history, extend the genealogic tree to at least 2 generations because skipped generations may occur in bleeding disorders, especially hemophilia. Aside from family history, look for acquired causes of bleeding. Ask about medical problems of the patient that can predispose him or her to bleeding or easy bruising, such as cirrhosis, renal disease, hypothyroidism, paraproteinemias, and autoimmune diseases such as SLE. Some leukemias, especially acute promyelocytic leukemia and lymphoproliferative disorders, may present initially with spontaneous hematoma formation. The nutrition history is also relevant to determine if the patient may have vitamin K or vitamin C deficiency, general malnutrition, or malabsorption that can alter the integrity of the blood vessels and predispose to easy bruising. And lastly, elicit the drug or medication history. The most common medication culprits causing easy bruising or even bleeding are the antiplatelets and anticoagulants. There are also some antibiotics like levofloxacin, cefazolin, and cotrimoxazole that can interfere with the synthesis of vitamin K-dependent clotting factors and lead to bleeding. Also, inquire about non-prescription drugs like herbal or alternative medicines and dietary supplements because these can also cause easy bruising and bleeding episodes. Prime examples are ginkgo biloba and ginseng, which are the most commonly used herbals that can cause platelet dysfunction. NSAIDs, fish oil, and even vitamin E supplements have also been associated with abnormalities in platelet function. Now, as I mentioned previously, several standardized questions have been developed in order to more objectively evaluate the bleeding symptoms of the patient. I will present here the Bleeding Assessment Tool, or BAT, designed by the International Society of Hemostasis and Thrombosis. This was primarily developed for identification of congenital disorders of hemostasis, but have been recommended as part of screening for patients with bleeding or bruising symptoms. It comprises 14 categories for assessing bleeding symptoms retrospectively, and it has been shown that a high bleeding score is associated with the presence of an inherited bleeding disorder. Each of the 14 variables is scored from 0 to 4, except for CNS bleeding, when the scores are 0, 3, or 4. And on the basis of this is a final score derived. The BAT has a sensitivity of 49% and specificity of 53%, with a positive likelihood ratio of 1.04. So in this tool, the patient is assessed for the presence and severity of epistaxis, cutaneous bleeding, bleeding from minor wounds, oral cavity, GI bleeding, hematuria, tooth extraction, surgery, menorrhagia, postpartum hemorrhage, muscle hematomas, hemarthrosis, CNS bleeds, and other bleeding. It is considered abnormal if the score is at least 4 in males and at least 6 in females. But while the BAT has been incorporated in some algorithms for bleeding evaluation, keep in mind the limitations of the tool, that it was mainly developed to detect congenital disorders and are relatively insensitive to acquired bleeding disorders. After eliciting the history, we look for objective evidence of bruising or bleeding, such as petechiae, purpura, ecchymosis, or hematomas, as mentioned before. Aside from these cutaneous lesions, we also inspect for other possible areas of bleeding. Look at the conjunctivae and palms for pallor, palpate for the liver and spleen, and check for lymphadenopathies that may suggest a hematologic disorder. Lastly, assess for joint hypermobility or hyperelasticity of the skin that are manifestations of Ehlers-Danlos syndrome. Now, if findings from a detailed history and PE raise the suspicion of a hematologic problem, these are the basic screening tests to request for. A complete blood count to evaluate the adequacy of the blood cell lines, especially the platelets, should be done. The peripheral blood smear should also be reviewed to assess the morphology of the platelets, whether there are large or giant forms of platelets or platelet clumping. The peripheral blood smear may also reveal abnormal cells that suggest a hematologic malignancy or a microangiopathy causing thrombocytopenia. The coagulation parameters prothrombin and partial thromboplastin time, on the other hand, are requested to evaluate the integrity of extrinsic, intrinsic, and common pathways of the coagulation cascade. Deficiencies in the extrinsic pathway result in the prolongation of the prothrombin time, whereas deficiencies or inhibitors of clotting factors in the intrinsic pathway will result in the prolongation of the partial thromboplastin time, or PTT. The bleeding time has traditionally been the initial test for evaluating primary hemostasis, but it has largely fallen out of favor and no longer recommended. It did provide a gross indication of overall platelet function and the activity of collagen and von Willebrand factor involved in the interaction with platelets. But a lot of factors affect its accuracy, such as drugs, comorbid illnesses, physiologic factors, test conditions that may not be platelet related. Also, it is very operator dependent, and its reproducibility is affected by multiple technical factors. Because of all these, the bleeding time has been deemed obsolete and an unreliable indicator of primary hemostasis. This table lists some of the common differential diagnoses for easy bruising and clinical clues aside from the evidence of cutaneous bleeding. First would be drug-induced platelet disorders from antiplatelets and drug-induced immune thrombocytopenia from quinine, heparin, and some antibiotics. We can simply determine the presence of these drugs from taking the medication history of the patient. Next are physiologic or external factors causing easy bruising. Benign purpura simplex is increased bruising, usually on the upper thighs and arms due to fragile blood vessels. It is usually seen among women, and the timing may be near menses and does not present with other bleeding episodes. Senile purpura, also called actinic purpura or solar purpura, is a disorder of connective tissue presenting with dark ecchymosis on extensor surfaces of forearms, usually seen among elderly persons. This is considered to occur because of chronic sun exposure. Physical abuse should be considered if the pattern of bruising is atypical, not consistent with the history, or the bruises appear in the pattern of objects. Nutritional deficiencies are also common causes of easy bruising, particularly vitamin C or scurvy and vitamin K deficiency. Alcoholic liver disease should also be considered if there is a history of alcohol use or abuse, gynecomastia, scleral icterus, spider angioma, or splenomegaly. Now let's go to the more serious causes of easy bruising. Thrombotic thrombocytopenic purpura and Hinoch-Schönlein line purpura are thrombotic microangiopathies that present with hemolytic anemia and thrombocytopenia. It is the drop in platelet count that causes petechiae or purpura to occur. The presence of anemia, jaundice, neurologic symptoms such as headache, lethargy, confusion, or focal motor or sensory deficits, and renal insufficiency are other clinical clues that should raise the suspicion of these hematologic emergencies. Malignancies such as acute leukemia and lymphoproliferative disorders may also present with easy bruising initially, also related to the decrease in platelet count. If there is also pallor indicating anemia, lymphadenopathies, or splenomegaly, then consider the possibility of a malignancy. Inherited or autoimmune disorders are also considerations for patients with easy bruising. If there is also significant bleeding episodes like epistaxis, gingival bleeding, and menorrhagia, this would yield a high score when using the bleeding assessment tool. So consider a congenital bleeding disorder such as von Willebrand disease. If the easy bruising is associated with malar rash, arthralgia, oral ulcers, or a family history of autoimmune disorders, then consider systemic lupus erythematosus. Other connective tissue disorders and collagen disorders like Ehlers-Danlos syndrome should be suspected if there is also hypermobility of joints and hyperextensibility of the skin. And lastly, immune thrombocytopenia is the most common cause of isolated thrombocytopenia in clinical practice, and it presents with mucocutaneous bleeding. Getting the complete blood count and seeing an isolated severe thrombocytopenia will support this differential. Now let us see a few clinical scenarios of easy bruising. Case number 1 is a 19-year-old female, nulligravid, who presents with several bruises on her right upper extremity and right thigh. She denies any gross bleeding episodes. We ask about her menstrual history, and she reports having regular monthly menses lasting for 3 days, consuming around 2 pads per day fully soaked. As for hemostatic challenges in the past, she had a tooth extraction back in 2018 and a skin punch biopsy in 2020, both of which had no complications. Her drug history and family history were both negative. If we were to use the bleeding assessment tool, she will only get a score of 2 for cutaneous bruising, which is not supportive of an underlying bleeding disorder. Despite your assurance that her easy bruising does not appear to be associated with a serious bleeding disorder, the patient insisted on doing workup. So you requested for the basic laboratory tests CBC, and coagulation parameters, all of which were normal. What could be the diagnosis? With a sole presentation of bruises and ecchymosis in a young female with a BAT score of 2 and normal laboratory results, the likely diagnosis is benign purpura simplex. Let's go to case number 2. This is a 29-year-old female, single, nulligravid, with a 1-month history of easy bruising after light trauma, or sometimes occurring spontaneously. Upon eliciting the menstrual history, she had an increased flow of menses from her usual 3 pads per day to 8 pads per day during her last menstrual period. She denies drug intake as well as any family history of bleeding problems. She had no prior surgeries or dental procedures. Physical examination revealed multiple ecchymosis on both upper and lower extremities. Using the bleeding assessment tool, she will only get a score of 3 for cutaneous bruising and menorrhagia, which is also not supportive of an underlying bleeding disorder. But because of the menorrhagia and the easy bruising, you decided to do basic laboratory workup. So the PT and PTT were normal, but the CBC revealed a platelet count of 8. What is the diagnosis? In a young female presenting with easy bruising and menorrhagia with an isolated severe thrombocytopenia, it is most likely that she has immune thrombocytopenia. And our last case is a 35-year-old female who experienced fever and body malaise 1 week prior to consult. She noted bruises on both upper extremities with an erythematous rash on both lower extremities, as well as bleeding from the gums when she was brushing her teeth. She was then brought to the ER when she became very weak and lethargic. She had no comorbid conditions, no prior surgeries, and no intake of drugs. Family history was also unremarkable. Upon physical examination, she was noted to be obese, had pale conjunctivae, slightly icteric sclerae, pale palms and soles, multiple purpura on both upper extremities, and petechiae on the lower extremities. Using the bleeding assessment tool, she scores 3 for cutaneous bruising and oral cavity bleeding, not supportive of an underlying bleeding disorder. However, due to the presence of other clinical clues, diagnostic workup is warranted. The CBC confirmed anemia with a hemoglobin of only 49 grams per liter and severe thrombocytopenia with a platelet count of 5. The noted scleral icterus also prompted the request for a reticulocyte count, which was elevated. Her PT and PTT were both normal. Notable also was her creatinine level, which was elevated. What then is the diagnosis? In a female patient presenting with mucocutaneous bleeding, weakness, fever, and sensorial changes with laboratory evidence of bicytopenia, that is, anemia and thrombocytopenia, reticulocytosis, and elevated creatinine, a microangiopathy, likely thrombotic thrombocytopenic purpura, should be the primary consideration. So, in summary, we have reviewed the normal hemostatic system, both primary and secondary hemostasis, and the clinical manifestations when there is a defect in each part, the general approach to a patient with bleeding or easy bruising, the common differential diagnosis of patients presenting with easy bruising, and the utility of the bleeding assessment tool in 3 different cases. Evaluating patients with bleeding or easy bruising is a multi-step process, and it cannot be overemphasized that a detailed history, especially the bleeding history, and a thorough physical examination are necessary for proper diagnosis. The clinical information obtained from these should dictate the selection of laboratory tests and the extent and direction of further testing. If initial laboratory tests are not diagnostic but clinical suspicion for a hematologic disorder remains high, then a referral to your friendly hematologists can always be done. Thank you for your attention.